Evening all, my name's Eloise and I've been a pharmacist for 20 years and welcome to my live stream. Welcome to anybody that's been before, my regulars, and to any new people. I'm going to do this live stream about migraines, about different types of migraines, the triggers, about keeping a headache diary, about the acute medications that can be given during a migraine, how they compare to each other, the preventative treatments for migraines, and as well as the preventative treatments that can be given in primary care, also when to get referred to a neurologist and the newer agents that are now available for the neurologists to prescribe, the monoclonal antibodies known as the mabs that are in injection form, and more recently the gepants. Yeah, it's a rather weird name, which are similar to the mabs but are in tablet form, and there has been one that's just been released for NICE approval in the UK, although I'm doing some research, it has already been available in America for the last 3 years, so I'm going to cover that as well. Hello Amanda, nice to see you online. I'm just going to, and Lynn, I'm just going to give my quick introduction. I am going to, before I jump into it, wait for a few more people to come online, and while I'm doing that I am going to do my disclaimers. So the information that I'm going to be providing is just for educational and entertainment purposes only. I'm not going to be diagnosing anybody or recommending treatments for individuals on this, but if anything I say is of interest, make sure that you go and talk to your own individual health professionals and even ask for a referral onto a neurologist to talk about the options. Also, I am based in the UK, and so I'm going to be talking a lot about what's available in the UK from GPs and neurologists and what has been NICE approved in the UK, although I have done a little bit of research about what is already available in the US as well. And also, I am going to do the YouTube intro and plug the fact that if you can like this stream and also place comments on it, it will help the YouTube algorithm promote this further so that more people can have advice on their migraines. And also, if you can make sure you're subscribed. For some reason YouTube keeps unsubscribing people, and every day it seems to unsubscribe somebody, and I'm hoping it's not that I've done anything wrong and that's why people are unsubscribing, and it's just YouTube timing people out. Right, let me get bang. Welcome, Jolene. For some reason, the emojis don't seem to show through on StreamYard, which is a bit annoying, but obviously it says that you're doing a pink waving hand. That will be the first thing I cover, Amanda, that a headache and a migraine are two different things. I will cover about sort of that antidepressants may or may not be useful with migraines. So they are two things that I will be sort of discussion. But to start with, the first question is, a headache and a migraine are two totally different things. So a headache is obviously when you've got pain in your head, and it can be from numerous different sources, which can include one of the symptoms of a migraine is a headache, but there's also lots of different reasons for headaches, the most common usually being tension headaches, although tension in muscles can also be a trigger for actual migraines. And then there's other different types of headaches. There's cluster headaches, which usually gets termed into migraines but are separate, but they still need a neurologist to diagnose. Obviously, there can be headaches from head trauma, and you can also get headaches when there's other things going wrong. But a migraine, although there may or may not be the symptoms of a headache, a migraine is actually a totally different condition. It's actually due to the blood vessels in the cranium of your head opening up, and during that process there's inflammation that happens and neuropeptides are released, and the increased blood flow causes the symptoms. But it doesn't only happen in the head. It actually is a systemic reaction and can cause problems all over. So migraines can be either with or without aura. When they talk about an aura, this is sort of symptoms that's prior to the usual headache part of the migraine, and usually counts as visual disturbances. Usually people see flashing lights, flickering lights, parts of their vision blurred. They may also have some sort of facial weakness or even body weakness. Some people actually hear sounds, get dizziness, get tinnitus. All of these can be the auras. So there's migraines with auras and without auras. There's even a type of migraine where the person only gets an aura and then it doesn't actually develop onto a headache. So as I've said, that yes, the majority of migraines have headaches, but not all migraines always have an actual headache component. Plus, there's other symptoms such as there can be weakness down one side of one side of the body. There can be dizziness, and then the main ones that usually are the most debilitating is nausea and vomiting, and just an inability to be able to cope with noise, light, needing to be in a dark room, and just your body just being totally overstimulated and not being able to function. And these symptoms can last anything from 6 hours to 72 hours. There can be very big differences. And so there's many different types. There is actually a type that is just an abdominal migraine, where you don't ever get the headaches, and it is purely related to the stomach, and it is also related to another condition called cyclical vomiting syndrome, where people will have these periods of vomiting for no apparent reason, and they just continually vomit for maybe 72 hours at a time. So there's lots of different symptoms. All I can say is if you've got symptoms and you think that any of them slightly relate to being a migraine, go and see your health professional and get a proper diagnosis. Also, even if you have a diagnosis of a migraine, make sure that you keep record of what your migraines are. And if you suddenly have any different symptoms that are not normal for your migraines, get them checked out. So as I've said, one-sided weakness can be a sign of hemiplegic migraines. But if you're not used to getting that symptoms, then it is worth getting it checked, because obviously there can be a crossover to the symptoms with that of a transient ischemic stroke or a full stroke, so either a mini stroke or a full stroke. So it is worth always getting that checked out. So I'm just going to go through some of these comments so that I keep track. I know last time I ended up missing a few questions, so if I do end up missing a question, you can repeat the question further down. I don't mind, and I do apologise if I end up ignoring anybody. I don't ever mean to do that on purpose. Used to get untuned TV screen. There's lots of different ways how people describe it. When I get my migraines, I see it as sort of like flickering stars. Like if they put like a filter on with flickering stars, it's like that just down one side of my face. It's usually always this side it starts, then quite often I'll have, it can be debated whether you have a cycle of a migraine or whether they're individual migraines, but I usually have it on this side to start with. And then maybe 12 hours later, it can then start on the opposite side. And then maybe 12, 24 hours later, it'll then go back to the original side. And I usually end up with it twice on one side and once on the other. But yeah, what is good to do is keep a headache diary and keep that so that you know what is normal for you and what isn't. Your crystal vision, I like that. Yeah, like a bit like kaleidoscope. Yeah, static minutes. Yeah, and quite often, yeah, the aurora is just at the beginning, and then once that's finished, and that finishes once the other symptoms start, which is why quite often I think I do get a second or a third migraine, because that aura comes back. Oh no, Laurie. Yeah. Migraines really do suck, and they are usually at the worst possible timings. It's usually when you've planned to do something, and I think sometimes it can be the stress that you've planned to do something that can be the trigger. I'm going to go through some of the triggers in a bit, but yeah, hopefully you can catch the replay. It will be here for everybody, even if you can only manage 10-15 minutes at a time. And then maybe if you want to play back in the dark and just listen. So yeah, feel better, Laurie. Hi Sam, great to see you again. Lots of things, right? Yeah. So yeah, take painkillers. I will go through some of the acute painkillers that are useful for a migraine attack. Yeah. So a lot of the abdominal symptoms quite often can be classic to that of IBS, and there has been some discussions in clinical research into whether some severe types of IBS may actually be abdominal migraines. So there can be the nausea, the stomach cramps, the griping pains, and the diarrhea and the vomiting. So basically, you've got similar sorts of pathways in serotonin, and this is probably going to think, but there is some pathway on the serotonin in the nerves and the blood vessels in the brain which causes migraine. Well, them same sort of nerve pathways and blood vessels are also around your stomach and intestine linings, and so there is potentially some crossover. So some of the treatments for migraine do specifically go on those pathways, and quite often many of the treatments are the sort of the anti-nausea. No, yeah, I know. I don't want to be a trigger for everybody's migraines, unfortunately. Blinded by light. Yeah. So that is one of my main triggers, is flashing lights. I remember my first and my worst migraine. Well, I think it was my first migraine. I'd probably have to ask my mum. I probably had headaches as a kid, but I don't think any actually were an actual migraine as a child. But I was away at university, and there was a big disco type event in our residential halls, and they obviously had strobe lights, and whoever was DJing didn't stick to the rules and regulations of how much strobe lighting is allowed, and the strobe lights just continued, and I ended up collapsing. Luckily, my boyfriend at the time carried me up to my room, and then I just pretty much don't remember anything of the next 72 hours, with just the flashing lights, the headache, the nausea, and such like. And then from then on, migraines have been triggered. It is normal for migraines to start in adolescence, although some people do have them from being younger. It's also common, especially in females, for them to trigger during sort of puberty and hormones. So yeah, light is one of the main triggers. Yeah, luckily mine never lasts for more than 72 hours, but yes, migraines can last for quite a long time. And also what I like to call as the post-migraine fog. So even when you actually recover from the migraine, you are left with that sort of foggy feeling, brain fog, that you basically, your body and your brain has sort of been hit by a bus and you're trying to carry on. Yeah, so strobe lights trigger epilepsy as well. And I think there may even be some connection, because obviously some of the anti-epileptics are used as preventative for migraines. And well, neurology is extremely complex. Nobody really understands the brain. There's so many pathways within the brain, the amount of neurons, the connections, it's extremely complex, and we still don't understand why things like antidepressants work. They seem to think that they did say that you need serotonin as your happy hormone and you need it. That's why serotonin reuptake inhibitors work, is by they increase the amount of serotonin floating around. But then they've actually found that actually the reverse may be true, and actually that might not be how it works. So we still don't know. Okay, so first one when you was about 19, 20. Oh, yeah. Sunlight bouncing back off snow can be, yeah, very blinding. That's why quite often when people go skiing and such like, they all wear sunglasses because of the glare back from the snow. Yeah, and again, yeah, end of teenage years is a similar age. So I'm just going to talk about sort of, if you do have migraines or you think you've got migraines, the best thing to do is make a headache diary. And that's so that you can have documentation of how bad they are, how frequent they are, for letting your health professional know, your GP and your neurologist. The quicker that you start doing a migraine diary, and the more information that you've got, the quicker then it can be for getting them to make a diagnosis and then to refer you on to a neurologist. Because to get a referral on to a neurologist, you need to prove that the migraines are chronic, that they're continually happening at a certain frequency. So it's always useful to do the headache diary. It'll also help you to find out any triggers and patterns, any warning signs. And then if you do start medication, it'll help you find out which medication is working the best, which combinations of medication is working the best. So when you do the headache diary, it's good to write down the date of it happens, which day of the week it is. Sometimes it can happen as stresses and changes in your lifestyle during a week. Certain day of the week could potentially always be the trigger. Also the time of day, because it could be when you've missed meals or due to sleep. So the time of the day is useful to write down sort of how long it happened, how long it lasts for, and how bad it is, the severity, and then sort of, what any other symptoms that happen. Did you have much of an aura? How long did that last for? Is it causing any dizziness, weakness, sensitivity to light, to sound, and then obviously any gastro symptoms, so any nausea, diarrhea, such like. And then also then documenting each time what medication you try, so that then when you can look back afterwards, you can actually see how well they work. Also, if you can find a way, even if you even set up maybe your Alexa or your Siri, if you're not able to do any writing down, to just document what medication you take, so that you can keep an eye to make sure that you're keeping to the frequencies and you're not taking too much. I know it can be very disorientating with a migraine to know how many hours have passed and whether you're actually allowed to take the next dose of the medication. So hopefully that's covered the reasons why you do a headache diary. When it comes to triggers, basically with a migraine, pretty much everything can be a trigger. And it can be anything that you've done from 6 hours before to even 48 hours before. And it can also be maybe when you only have certain combinations of things. So maybe that a certain amount of cheese and caffeine is fine. But if it happens to be when you're also tired and extremely stressed, then it's not okay and it does trigger. So sometimes it can be looking to see, well, I can cope with 2 out of these 3 situations, but I can't cope with 3 or more. And that's the trigger. So routine changes is a big one. So if you're suddenly changing your sleep pattern, staying up later or sleeping in later, if you're missing meals and not having regular meals, if you've suddenly got a lot of stress at work, also with the routine with your hormones within the month, for menstrual migraines, these quite often happen around menstruation, sort of 5 days prior to up to 2 days after you've started menses, is the common time. Now that does cause a bit of an issue with then looking for the treatment, because the treatment could be to have hormones, but then you need to have a discussion about the pill, because actually sometimes migraines with aura, taking a pill can very slightly increase your risk of stroke. So that's something that you need to have a risk benefit discussion with your healthcare professional, whether to treat with hormones or not, because treating with hormones could prevent the migraines, but there may also be the increased risk of problems. I'm just like that. Yeah, so hi Lisa, and hi Julie. Yeah, it would be great to see you on the replay. So for any of the people that are coming back to the replay, remember after the live stream, if you don't get to ask your questions here, ask them in the comments afterwards, and I will do my best to answer them there, or even make another live stream or another video. So I've mentioned sleep caffeine. So we've already covered bright or flickering lights. That then also goes on to computer screens, even TV screens, cinemas. I do find if the cinemas, if they decide to do a strobe light in the cinema, I'm not very good. I can't watch things like Alien, where I know that there's going to be strobe lights. My daughter's pretty good at telling me to cover my eyes, and she'll tell me when the strobe lights stop again. But yeah, computers. I don't think tablets and phones are as much, but if you were using them in a dark room and they're flashing a lot, there still may be a trigger. Yeah, menstrual migraines. Yeah, and they can, because you've already got issues with menstrual pain and menstrual cramps affecting that area, and you've got the higher levels of prostaglandins causing issues down there, then yeah, it probably menstrual migraines can then affect the intestines and affect more of the abdominal type of migraines. There's certain foods that are known triggers, and it's because they contain certain ingredients. One of them is tyramine, that's found in red wine and certain cheeses, usually more of the soft cheeses. So I know my mum's not pretty good with cheese and wine evenings, even though she loves them. There's also monosodium glutamate can be, aspartame, chocolate, caffeine, and alcohol. Although there was a bit of research to say whether was chocolate a cause or effect thing, because they actually do think, because migraines actually start long before you realise that they're starting. Your first symptoms are the aura, that actually you may be craving them in the pre-migraine phase. So you actually crave chocolate or you crave cheese prior to the migraine. So you eat it and then you think it was a trigger because you actually ate it. So there is a theory out there for that, but all you can do is keep a headache diary and then try seeing whether stopping it reduces the frequency of your migraines. That is interesting. I was just about to say that some people do seem to think that there may be a link between people that are gluten sensitive or even celiacs and them having a higher amount of comorbidity with migraines, and that there may be some inflammation based anti-immune connection there. So yeah, so wheat-based products may be a trigger for some people, so it's a good thing to make sure that you keep that documented. Hi DC, great to have you here. Yes, so application for blue light on your screens. There's a lot now on a lot of tablets and phones now actually come within their settings to set to reduce the blue light and have evening settings. They've mainly done it, I don't think they've done it for migraine sufferers. I think they've mainly done it to help with sleep, so that people can carry on using their tablets and phones later on in the evening, and in theory preventing that blue light that's going to suppress the melatonin production and therefore sleep. I did also know, Actis, I was on the Migraine Society website. They had a useful point at the top which said, is this page too bright? Press to darken it. So yeah. And also, yeah, there are glasses, so you can always ask your optician if there's any sort of glasses or filters that they can help with. I know some people find having the automatically adjustable lenses that when you go into bright light, they all automatically darken, can really help. Oh, hi, yeah. Oh, hi, Erin. Great to have you here. I will say, for anybody who doesn't already know, Erin and DC, they both have really good channels debunking MLM companies, and I very much join with them in sort of debunking the crazy medical claims that they make. But they also go into things about the bike model and how they are basically commercial cults where they manage to get people to spend too much money without actually getting the that actually even earning any money back, and definitely not enough to pay back what they've spent. Of course, Erin, you always shout me out on your channel, so it's great to have you here. Yeah, so I would say with elimination diets is to try not to eliminate too much at once. It can also be useful to make sure that you go through it with a dietitian as well, because you really need to know where hidden things are. So if you are trying to eliminate one item, finding where it's hidden in different products. Also, you do run the risk of, if you do too much of an elimination diet, you can actually be eliminating some of the micronutrients and such like that you need. So, yeah. Oh, I forgot to say, yep, sinus headaches. Yeah, they can be awful as well. And people can have multiple different causes. So just because you've got a diagnosis of one type of migraine, that doesn't mean that every time you get a headache, it is that type of migraine. Just because you're suffering from one thing doesn't stop other things happening. So yes, I have migraines, but then when I had a sinus infection and I was getting sinus headaches on top, yeah, they can compound on each other. So the other things with triggers, blood sugar drops, dehydration, tense muscles, and as I said, there is tension headaches, but then also tension in the muscles can also trigger migraines, as can things like teeth grinding, because the place where, sorry, I've got my notes because of that. I just wanted to make sure that I cover everything, because it is actually due to the quite often the nerves and the blood vessels that run alongside of the face. The teeth grinding and the tense muscles can trigger that. So I wouldn't say it's just about migraines. There can be a there can sometimes be sort of just the fact that they assume that because women still manage to carry on and do things, that it can't be as bad as they're moaning about, because they're still actually functioning on a day-to-day basis. And that can quite often come, which is why I do say make sure that you write a full-on diary, really record it, because there can be a tendency to downplay sort of women's pain levels and what they're actually coping with, because they quite often have the ability to just muddle on because they don't want their kids to go without, they don't want their family to go without, and they really try. So yeah, it can be, but I would say make sure that you make a note, and also take along somebody to advocate for you. So if you feel as though you're not being listened, get somebody, even if they've got a bit of healthcare background, to sit with you, all the better. But if just somebody that can actually say, yes, I see you, they look okay while they're sat here, but I've seen them 3 days laid straight on the bed, unable to function. And they can be that advocate for you and say, look, no, we've already waited 6 months. We've already waited 12 months. We need something doing. We've already tried this list of medications. We need to try something new. Yeah, there are good doctors out there and good neurologists. So, you look right, wrangling the floofs. I love seeing your floof cam. I don't know how to set that sort of thing up. Currently, one of my cats is on my bed, the other is on the sofa with my daughter playing Xbox, and the 2 rabbits are outside. But I probably do need to work out how to do a floof cam. Yes and no. There is a certain amount of the fact that if migraines are due to tension in your neck, having the massage and releasing the tension in your neck can help. Personally, I would probably go more to somebody that's a sort of sports massage person to help relieve that tension. As for the realigning of joints, that is best done by actual looking at your posture and doing physio exercises to realign, making sure that you're sat in the best posture possible and you're doing things correctly, rather than actually manipulating the spine. The spine vertebrae and your spinal cord are very delicate, and it's probably not something you should be messing about with. So I'm not so keen on that, even though I have had a chiropractor and I did find it helpful. But then when I realized that I'd got EDS and the risk of actually the vertebrae moving too much and causing issues, I then stopped. So okay, I'm going to try and do my best to go through what I've got as my notes and answer the question. Sometimes it can take somebody actually mentioning that there might be a crossover. Quite often they are just busy thinking about one thing at a time, and they forget to ask about the other parts. But yeah, it's like with my Eloise, it took a while to realise that actually my blood pressure problems and my IBS problems and potentially my migraine problems are all linked to the EDS. Yeah, massage for migraine. If you've got tension in your muscles, sometimes actually the massage can trigger the migraine. It can cause the migraine to come out as such like. So I've sometimes found that when I've actually paid and had a massage, I've then ended up with a migraine the next day, and it's as if my body's just gone and gone. You've tried to get rid of the tension, and I was actually sort of holding myself like that, and now I don't know what to do. So yeah, Lynn, yeah. But once you know that your joints are prone to moving too much, then yeah, having somebody then move them too much can be a risk. I can throw my joints out anyway. The only time I've gone back to a chiropractor was to put a joint back in. So when my shoulder was out and I couldn't get it back in, I did go to a chiropractor to put it back in because it was easier and quicker than going to A&E. You're not the only one. Yeah, posture's hard. I do all these things, try and make sure. But yeah, posture is hard. Then it ends up with tension. Then it ends up with just my head's too heavy to hold on the top of my head. Yeah. So, as I said, one of the main things to go through is trying to work out what your triggers are and then limiting those triggers. Because although we've got medications for treating them, the ones for treating the acutely, once you've got the migraine, all you're trying to do is reduce the length of the migraine and reduce the severity of the migraine. Because once you've got a migraine, you've got a migraine, and you've got to, it's got to run its course. So you're sort of fighting a losing battle once it's started. And so really the when it comes to acute medications, although they should be given, if you've got more than 4 migraines a month, you should also be looking at the same time of starting preventatives as well as starting the acute medication. You shouldn't just be relying on the acute medication because you're actually too far down the line then. So usually acute medications are useful if you say you're having just 1 a month and you know when it's going to happen, and then you can plan around that. But if you're having sort of 4 or more, then you actually do need to be thinking of preventatives. And I would say not even necessarily having to have 4. If you're having it and they're lasting for like a whole weekend at a time, well, you may be wanting to start something preventative even at less than that. Yeah. I understand, Lynn, and I think a few others on here with EDS, we totally get that. I actually found somebody with EDS this week and just info dumped on them, and they said they learnt more in half an hour of me info dumping than they had for a long time. Taking the meds beforehand. As soon as you feel the start of the aurora, that is when you need to take the acute medication for a migraine. As soon as you think a migraine's coming on, don't wait to find out how bad this migraine's going to be going. Take it then, especially if you're going to end up with the point that you're going to end up with nausea and vomiting, because the earlier the better, so that you can actually get it into your system. Because once you've got nausea and vomiting, you're not actually going to be able to take anything that you swallow. It's just going to come straight back up. So yeah, the earlier the better. Oh, fairy lights can be very cute because people will just think you're being Christmassy. 3 migraines. Oh, yeah. But yeah, it's got to be a multiple effect. The thing is, we're trying with medication, we're going to be trying to reduce the frequency and the severity. With knowing your triggers, we're going to be reducing the frequency and the severity. Unfortunately, once you're a migraine sufferer, you're a migraine sufferer, and we've just got to try and reduce it so that it's at a point that it's not impacting your daily life too much. Unfortunately, when it comes to most things medication-wise and medical-wise, we never actually can fully cure and eliminate. Oh, the vampire cave. Well, my daughter has a vampire cave, but she's she's just a teenager. Yeah, so tiredness can be a symptom. So fatigue can be a symptom, but also the tiredness from other causes can also be a trigger. But yeah, and so it can be hard. It can be really hard to know when they're coming. Yeah, and then yeah, they can take you out for days. So when we come to the medication, triptans have been the gold standard for probably about the last 20 years. Now, I remember back 25 years ago when I was at uni, I remember them using the pharmacological method of how triptans were actually created and discovered as one of the main lessons of the new novel ways of doing drug development, because sort of pretty much sort of decades ago it used to be, oh, we found this, and when people took this happened. So like with aspirin, people took willow bark and it helped, and then they found molecules similar. But with the triptans, they actually looked at the migraines, found out that when people have migraines, the there is the vasoconstriction and the cranial nerves of the blood vessels going to the brain, and then that releases pro-inflammatory neuropeptides. And it was all to do with these serotonin receptors in these blood vessels and in these nerve endings that was the trigger to a migraine. So the triptans were actually developed as being molecules that fitted into these receptors. They were serotonin receptor agonists. And this is why there can be interactions with serotonin selective reuptake inhibitor, antidepressants, and why that's there. But these were serotonin receptor agonists. So they actually specifically found the two different types of serotonin receptors. I think it's the serotonin receptor 1 and the serotonin receptor 5. And they developed it. They developed sumatriptan as the first one. And then from then on, there was multiple other companies that all did the same thing. So they were found this receptor, worked out how to do it, and then made very similar sister molecules. And each of them patented a sister molecule. So you've got your rizatriptan, noratriptan, zolatriptan, a whole range of them. And when it came to comparing them, some of the newer ones did work slightly better than the sumatriptan, but they were all pretty much a muchness. And so when they came out, they were all then fighting for the market of where they could try to claim that they were better than the others, try and claim that there was less side effects, but they were all pretty much the same, and then try and compare on price. But the main difference was they all tried to come out with new novel ways of people taking it, because they realized that yes, it's in tablet form was great as long as people knew to take it right at the beginning of the aura and right before they started with nausea and vomiting. And this was when there was a sudden jump forward in we're needing to find a way of getting these medicines into people that have got nausea and vomiting. And like you say, they came up with a nasal spray so that it can get absorbed through the very thin mucosa in the nasal cavity. It can get straight to the very tiny capillaries there. They did then hope that it would then travel through those capillaries, through the blood-brain barrier into the blood, through to the brain, but actually it possibly does go back to the main part of the body and then go back up again before that happens. And yeah, so there's the melt in your mouth ones. So these go either under your tongue, and then they use the saliva to dissolve, and then they absorb through the mucosa of the sublingual. There's also buccal, where you put them in between the gum and the soft part of the gum and the soft part of the mouth, and it absorbs through the mucosa there, again using saliva. Quite often people can struggle if they've got a dry mouth, because sometimes people get a dry mouth with the nausea. Some people have excess saliva with the nausea. But yeah, you may need to put a little bit of water in there as well. So that's why they came up. There was also sumatriptan injections, but people trying to inject themselves while a migraine was coming off, it never really did take on. But the triptans is the reason why the development of sublingual and buccal therapy really exploded. And then that got moved on to other medications, such as other pain relief and such like. And as we already know, some supplement companies have tried to claim that it makes their supplement better. But when you're taking it as a regular supplement, you don't need to have it fastly absorbing through the mouth. But yeah. Oh yeah, I was saying, so yeah, there is a difference in price, and every time they fetched a new device out, they would patent the new device and try and spend more money on that. So, but a lot of the triptans now are pretty much the generic companies are out there able to make the melts and the sprays and such like. So the cost of them, at least in the UK, is fairly low. I'm not quite sure. I wouldn't be able to say for other areas of the the world, whether the companies are still out to make too much money. Yeah, you can take it before. If you know a migraine's coming on, take it as early as possible before the nausea starts. As soon as you've got that aura, you can take it. I think I've missed something. Oh, an app. Oh, right. So you've got the nasal spray. It's expensive, right? Yeah. It is really annoying when you're bound by what insurance will pay for in other countries and how much they pass the cost on to you. So yeah. So got national health $50. Yeah. So yeah, unfortunately, yeah, it is trying to work the cost effectiveness. So with the triptans in the UK, we do sort of quite often put a restriction on how many people can have in a month, but that isn't because of cost now, because they are all pretty cheap to the NHS, and we do try and encourage the melts that are the cheapest. Each area might have a formulary of which they prefer is the cheapest. But the reason that we quite often restrict how many people can have is we usually restrict to the use of 8 a month or less. And that's due to a thing called medicines overuse headaches. And this actually accounts for all the acute medications, except for the new one that's come out with overuse. So if you use any sort of triptans, but this is especially more so with paracetamol, codeine, and the opioids, if you take them for headaches more than 8 times a month, you can then get what's classed as a medication overuse headache, of the fact that if you don't take that medication and you've been taking it for more than 8 a month, you'll then get a headache and a migraine that is actually due to the fact that you've overused this medication, and then you sort of need to use the medication before. So you end up with people that are needing to take medication for headaches pretty much most days of the month, and it is because of this medication overuse headache. And the only way to then get rid of that is to totally cold turkey not take any acute medications for migraines and headaches for a month, to sort of get it out your system and reset. So, right, so this is specifically for headaches. So if you were taking any pain relief for any other chronic condition, then you don't get these medication overuse headaches. It is purely when you're taking it for headaches that it then causes the medication overuse headaches, which is the thing. But it mainly happens with paracetamol and codeine. And that is the main reason why they no longer recommend codeine to be used in migraines and headaches, because of the medication overuse. So codeine and opioids really shouldn't be used for migraines and for headaches, even though historically a lot of people still do. A lot of people still go straight for them. It's even what's in one of the types of migraine relief tablets. So it's hard to sort of break that. So the codeine and the opioids really shouldn't be used, plus the fact that they also increase nausea and increase vomiting, which obviously would accentuate the symptoms of the migraine as well. So the best option, if tolerated, is NSAIDs. NSAIDs are the ones that they actually reduce the inflammation. That's the inflammation that's actually happening in the nerves and blood vessels. The actual, prior to the triptans, all the evidence would show that the best treatment was 900 milligrams of aspirin. Unfortunately, not many people can tolerate that higher dose of aspirin, and definitely can't tolerate that higher dose of aspirin on a regular basis. So the next best out of them was naproxen. So naproxen, 500 milligrams, is the next best if can tolerate it. Again, it is quite harsh on the stomach. However, you do need to be careful with naproxen. It comes in two forms. You have a normal release and you have an enteric coated release. Now, the enteric coated release sounds great, as in it protects your stomach and isn't released until it's in your intestines. Unfortunately, when time is of the essence in a migraine, it delays it being used, it delays it being absorbed by 2 hours. Well, 2 hours into a migraine can be pretty far into it and make it much less effective, and possibly to the point of it not being absorbed as much. So if you do take naproxen for migraines, make sure it's the instant release and there is no enteric coating on it, so that it does get straight in your system. If you can take it with a mouthful of a biscuit or something to help with your stomach, that can be better. Right, I'm not too sure, but there is something to do with how it is. I'm not exactly sure on the full pharmacological by it. So, yeah. So you just have to be. You don't need to be scared of it. You just need to be something that you need to be aware of. That if you're starting to take the acute medications too often, that you may need to have a break and try and reduce them, and then start back on. And if you are getting them too often, you really need to be going down the preventative routes. So, yeah, switching around between them. So the paracetamol, usually paracetamol on its own doesn't normally work for migraines, but adding it to the NSAID can really help boost the NSAID. Also, adding in caffeine, even though caffeine can be a trigger for headache, for migraines, adding in caffeine with your NSAID and your paracetamol can boost the absorption of the paracetamol and ibuprofen, and it sort of opens up and allows it to access the body quicker. So taking out, that's why you find that Panadol Extra and all of those, they have caffeine in them. They know that caffeine increases the absorption and the quickness of paracetamol working. That's why they've added it in there. So the other thing to have is that sometimes in anti-migraine medication, they add in an anti-emetic. So obviously one of the symptoms is nausea and vomiting. So some of the migraine relief and things maybe have a small dose of an antihistamine that has anti-emetic effects, similar to the anti-sickness tablets that you take for travel sickness. And then sometimes GPs can actually prescribe you stronger anti-emetics alongside, especially if that's the one of the main symptoms. And even some of the anti-emetics, they again have been developed so that they can be dissolved under the tongue, because obviously once you've got nausea, your anti-emetics aren't going to absorb as well. Right. Yeah, codeine does cause sick, so yeah, and that's it. Sometimes you have to fetch it back down the amount that you're actually taking, so that you actually do get the benefit when you take it. The only way you're getting rid of a migraine without medication is trying to reduce the triggers. Once you've got a migraine, it's a dark room, and just reduce the stimulus from outside until you allow your body to recover. Some people say that having coal on their forehead works. Other people say having heat on the back of their neck or having their hands and feet cold help. It's things of just finding what actually soothes you during a migraine to help. This is probably, I'm probably going to cover the supplements. So obviously, this is when you get migraines, you're going to have people claim every supplement every company are going to claim that they can cure migraines. Really, when it comes to supplements, there isn't really many out there that actually have any benefit. There's 3 that maybe have slight use. One is coenzyme Q10. Another is riboflavin. So those are 2 supplements that you could try adding that probably wouldn't cause any problems. But you could try adding them in. Again, with the migraine diary, try them for a couple of months, see if there's any change in the migraine triggers, severity and such like during that time. If there isn't, stop them, because there's no point paying for something that you don't need. But if they do, it may be worth keeping them in. And another one is magnesium. When it comes to magnesium, there's a lot of hype out there saying that magnesium is the wonder medication, wonder supplement. Quite a lot of people are lacking in magnesium. We find it in sort of green leafy vegetables and such like, and it could be worth trying. Also, if you are on certain medication like proton pump inhibitors, these can cause for you to have a low magnesium level. So if it is something you want to try, it may be something that you may want to ask your GP to just double check your magnesium level to see whether your magnesium level is low or is in range. And if it is low and they do think that you've on something like a proton pump inhibitor that's lowered it, then it's for you to have a risk benefit discussion with your GP, whether you continue that and take a magnesium supplement or you try stopping that. I do have to say that coenzyme Q10, riboflavin and magnesium, coenzyme Q10 and riboflavin are not available on the NHS. Unfortunately, the only products that are available that are allowed on a GP NHS prescription cost a ridiculously silly amount of money for no apparent reason other than the fact that they can get dispensed. So we do encourage people, if they want to try those, that really you buying it over the counter is much more cost effective and not cost effective to the NHS to actually get them on prescription. When it comes to magnesium, you'll only get magnesium on prescription if you've got a blood test that has shown it's low, and then you go for continual repeat blood tests to see whether you still need it. So I'm sorry, but when you've got a migraine, you're not in a suitable place to work. Your senses and everything, yeah. But yeah, I know I have driven home as a migraine is coming on, which probably wasn't the best thing to do in the world. But no, if somebody is wanting you to work while you've got a migraine, that is not appropriate, really. I personally would get them reported. Yeah, even working from home, because if you're working on a screen and such like, again, that you're probably just going to precipitate the migraine lasting longer, even if it is just at a lower level than normal. But yeah. So I think I've covered all the things that you can take as during an acute. So this is when you come on to a preventative. When it comes to, so if you're having more than 4 a month, or if it's significantly impacting your daily life, then you need to be thinking about preventatives. Now, there's 3 main types that a GP is encouraged to try and see if they get results with before they even refer you to a neurologist. So the first one, and I think somebody's already mentioned earlier and said they've got good results, is propranolol. And propranolol is one of the ones that I take. And again, there's some blood pressure tablets, and it is to do with the way that the blood vessels to the brain work. They also think with beta blockers, it's also to do with it helping keep your adrenal levels and your anxiety levels and your stress levels from cortisol lower, so to help with reduce the triggers. So propranolol is the main one used, but any of the alols can be used. So if you need to also have one of the beta blocker that all end in alol for any other reason, you may be given a different one. So sometimes people will have a tenolol because they also have high blood pressure. I do take propranolol. It is something that's helped me. You probably do need to take it for a good couple of months to see whether it works. Again, keep your headache diary. They can start at a lower dose and then increase it up. Another one, the only problem with beta blockers is obviously there is a contraindication with anybody who has got asthma, because it is the opposite to what the asthma reliever is, and it can cause bronchoconstriction. And if that's the case, then sometimes the calcium channel blockers, which are another blood pressure tablet that helps on the sort of the constricting of the blood vessels, that's amlodipine, felodipine, and they can be very useful, or even the verapamil and the diltiazem, although they're the older generation and not often used. And then sometimes they've done some studies on sartans as well, which is sort of the ACE sartan related blood pressure tablets. So yeah, I take my propranolol. It helps me with my essential tremor, my migraines, and my palpitations. I actually have low blood pressure, and because it regulates my tachycardia, palpitations, it actually increases my blood pressure up. Being on the propranolol, it sort of makes it back up. I think I've missed some. I'm just going to go back. It really does mean everything to have a boss that understands. It really does. I am so glad that my line manager and my line manager's line manager really understand sort of my condition and let me manage things from home if needed. Yeah, it can be really bad when you've got people. Yeah, and when they make you use vacation time instead of sick time. You know, if you're sick, you're sick. You should be able to take sick leave and it should be covered, but not every company has the same rules for sick leave, and then they force you to take vacation leave. And then if you don't have a vacation and lower your stress by having a vacation, how are you supposed to then function the rest of the time? Yeah. Yeah. So slurring and speech and sort of the function of your face can be symptoms. And yeah, people, if they don't always understand that it's a migraine that's causing that, then they can accuse you of being an alcoholic or being on something and such like. Yeah, it's not good. Yeah, so amlodipine and losartan, yeah, and they can both help with sort of prophylaxis. Oh, that's pathetic. I'm sorry. I do think that there is some national systems that need to be improved so that people can improve their work-life balance, and especially for people that have got chronic diseases and suffer with chronic conditions. So I've covered the blood pressure prophylaxis. The next prophylaxis are the tricyclic antidepressants. And as I said, sometimes they have used serotonin selective reuptake inhibitors and found that some people find them useful, but then they also, for some people, can actually worsen them. But the tricyclic antidepressants do seem to help a lot of people. Usually amitriptyline is the one used first line, and it's used in a lot lower dose. It's more used in the sort of the similar doses to what they use for neuropathic pain rather than in the antidepressant doses. So they use them in the lower doses and they can be really helpful. Unfortunately, the side effects of drowsiness, dry mouth can be particularly bothersome. And then in older people, it can sort of slightly impair cognitive function and isn't the best to be used for older people. So they can be really effective, but they're not always suitable for everybody. But if you've got somebody that's also got other chronic pain and chronic diseases, then it can be of help to have that amitriptyline in there. And help. So yeah, it's another alternative to add. These can be added together as well. It's not one or the other. So you can have propranolol, and you can have amitriptyline together. And they can have a sort of a small dose of both, can be better than a large dose of either one, because it reduces the risk of the side effects. Then the next group is anti-epileptics. And as I said earlier, there may be some crossover with the neurology of the two conditions. And the main two are sodium valproate and topiramate. Now, sodium valproate, they're probably never going to start anybody new on that due to its severe problems with risk of pregnancy and issues. We're seeing less and less. However, the other alternative, topiramate, has also recently had MHRA alerts about the fact that you must not get pregnant while you're on topiramate, because again, it's been related to problems with fetal abnormalities. So although there are two anticonvulsants that could be used, these can't be used of women of childbearing potential. And so when it is actually people of childbearing potential that have those hormones going around their body, are probably the larger group of people that have got migraines. There are also people that cannot be given these medications unless they submit to having a pregnancy prevention plan put in place, where they have like maybe an implant or a coil, and also take a second line of contraception to make sure that they definitely do not get pregnant while they're trying these. So not everybody is willing to do that. And also with these, as I've said, we're just trying to reduce the frequency and the severity of the migraines to a point where you can actually have work-life balance, maybe even be able to get to work. As well as fairy lights, I also like this. You can like get little presser lights that are little coloured presser lights. They're quite cool. I used to have them because my light switch was the wrong end of the room. I had a couple of those to press. So yeah, I'm feeling very, very privileged at the moment with the amount of vacation days and sick days that I'm allowed, unfortunately. Yeah. So, right. Wow, I've waffled for well over an hour, and I'm only just getting onto the fact of these new agents. So we now have two new types of medication. One is the injectable monoclonal antibodies known as mabs. And these are specifically because they know that when a migraine is triggered, there's the release of this CGRP and substance P neuropeptides, so calcitonin gene-related peptides are released. They've actually made monoclonal antibodies to mop that up and clear it out. So these are actually specifically made, biologically grown in a lab, monoclonal antibodies that will help clear up that peptide that is working in excess and causing the migraine. So there's three on the market: Erenumab, Fremanezumab, and Galcanezumab. The two longer named ones, the F and the G ones, are very, very similar in structure, and basically, if you've tried one of them, the other one is basically exactly the same. So if you can't tolerate one, you definitely won't the other, and if you don't respond to one, you definitely won't the other. However, the Erenumab is slightly different. So if you are struggling with the side effect from that one, there is potential to move on to one of the other two. So they are generally well tolerated. There can be the problem with injection site reactions. They can cause itching, but that's usually a side effect of pretty much any medication. And they can cause some cramps and muscle spasms in some people. But actually, when you come to a list of side effects, it's not actually that many. I'm just going to grab a drink. So they are generally well tolerated. Obviously, they are injections. They come in pre-filled syringes that are quite easy for most people to be able to be trained to give to themselves, very similar to like adrenaline pens, where you place the pen against, you take the lid off it, place the pen against your leg, and then press the top, and that will insert the needle and insert the medication straight in. The only downside to these is that they are quite expensive. They are about, classed as about over £300 a month, which is a significant cost. Especially when you think to all them others, we could get somebody on taking all the others, all the acutes and all the other tablet prophylactic medications, and it's still being sort of like less than 50 quid a month, whereas this is going to be 300 quid a month. So the NHS have come up with a price with the company, which is NICE approved, so that NICE guidance say the patient can have it as long as the company give it to us at this discounted price. That price is not allowed to be revealed to the public, so I have just had to quote you the price that the company have on their website as the cost. Obviously, in other countries where you're restricted by insurance and having to pay for yourself, they could potentially be charging you even more than that, depending on what your insurance covers. They are looking at being really good. They shouldn't. The NICE guidance approves for them to be used as long as you're having greater than 4 migraines a month. You've tried at least 3 other preventatives and they've not actually had an effect. And then you've got to have a review at 12 weeks. And if you've not reduced your migraines by 50% at that 12 weeks, then you have to stop it. You're not allowed to try it again. I suppose in the future, if your migraines change significantly, then there may be a rationale to maybe trying it again in the future. But yeah, we are getting more and more people on there, but this is now creating a larger demand on neurologists. So people are getting referred to the neurologist on these. And because these are a medication the neurologist has to keep the payment for and the reviewing for, and is not something that GPs can take, that then takes on 6 monthly and yearly appointments with the patient that they've got to continue, and reduces the time in clinic for new patients to get referred and into clinic. So obviously there's a call for the neurologist to have more staffing so that they can see more patients and get more people on these monoclonal antibodies. I think yes, Sam, that was a cat. That was my minnow. Come on, you're going to say hello to everybody. Now, this is Minnow. She is 3-year-old and crazy. She wasn't my daughter, so she's obviously got bored. Okay, now she wants to try and eat the computer. Yeah, so that's Minnow. I'm assuming Nobby might come in a bit as well and say it's food time. THC or ketamine. They're not available on the NHS for treatments in migraine, although THC is available on the NHS for treating certain types of spasticity with with MS, and for certain types of extreme epilepsies of specific types. They're the only reasons that THC can be prescribed on the NHS, and it has to be through a consultant. Ketamine can be prescribed again it has to only be by certain pain clinic consultants and for certain types of pain that is, just not responding to anything else. But migraine isn't covered in there. So yeah, they're not two things that are available on the NHS. As for what their evidence are in migraines, I'm not sure of. I've not looked into, because they're not available on the NHS, so I've not had need to. But I can look into that if you wanted me to. Yeah, lots of love for you, Minnow. She's now just sat next to me. Grandad says hello, Minnow. Hello, Grandad. I should say that's my dad. Obviously, he's the cat's granddad. And I'm going to finally get on to the new medication that has been on the BBC, has been newly approved by NICE in the UK, and it's called rimegepant. So these are a new group of drugs called gepants, so GEPANTS. And these are similar to the previous CGRP monoclonal antibodies, but instead of being the full antibody, they're just a section of it, so that they can actually be made in a molecule that is small enough that can be given in a tablet, absorbed through the mucosa, and then going to different parts of the body. So there's only one available in the UK, and it's the rimegepant. It's only just been released by NICE for two indications. One is the prophylaxis of migraines, but also for the treatment of an acute migraine. So unlike the mabs, which you have to have in your system and have an injection once a month, these gepants actually can have an effect on an actual acute migraine. And in trials, they've actually shown to be just as good or better than the triptans. Well, what we're calling the studies is non-inferior. So they're no worse than a triptan, and then potentially they may be better, but they haven't actually shown significance from that. However, when you look for the actual mechanism of action, the triptans cause the vasoconstriction, but they can cause that vasoconstriction more than the original dilation that actually happened. Whereas with the gepants, because they're only actually acting on the CGRP that's been released, the action that they take only ever takes it back to baseline and not too much. So they can therefore will have less problems and side effects to that of the triptans, and technically should be safer, because they're only removing the vasoconstriction back to baseline and not too much. So the product that's become available on prescription in the UK, it is a melt. It goes under the goes in the mouth, so it will be able to be dissolved easily. Unfortunately, it is quite expensive, and it is it could be costing up to £200 a month, which is why NICE have had to make a deal with the company to get it being given to the UK NHS at a lower price. Obviously, I'm not allowed to say what that price is. I just have to go on what the price is in the BNF that's publicly available. So it can be used acutely up to 4 times a month without the problems that the triptans have. And they also claim that it doesn't have rebound overuse issues. And it can also be taken every other day, because its action lasts as 48 hours. It can be taken every other day as a prophylaxis treatment. So 14 doses a month. It's a prophylaxis treatment. So the NICE guidance, there's 2 lots out there. One lot for if you've got less than 4 migraines a month, you can take it as an acute for those up to 4 migraines a month. Or if you have more than 4 migraines a month, you've been through the neurologist, you've tried at least 3 of the other methods, you've either haven't responded to the mabs or the mabs aren't appropriate, then the neurologist can prescribe these. Unfortunately, there isn't going to be any GPs out there that are going to be willing to prescribe this yet, as it's an unknown. We don't know about these agents. We don't know what the long-term side effects are going to be. We don't know what the long-term interactions are going to be. Obviously, there is going to be a cost to the NHS. Not that that always impacts on whether the GP decides to, but it will impact on whether somebody like me goes and tells the GP off for overspending their budget, because that's what my day job is. So at the moment, the only access to these is going to be via a neurologist. However, when I came to look at this, thinking, oh, this is a brand new drug just on the market for the UK, turns out that it actually has been in the US available for about 3 years. However, I think they've probably got similar sort of issues to here. It's not really taken off and being used that much by neurologists over there, because of the costs of it. So, and there is actually 2 other sister drugs to it as well. Also looks like that because they're wanting to get it used like the triptans are, sort of for an acute migraine, they are trying to make different, they're trying to make them in different formulations. So one of them is developing it as a nasal spray, and the other 2 are making it as dissolvable sublingual tablets. And so there's probably going to be some more thing, but because they're going to need to have the more sort of unusual technology of nasal sprays and sublingual tablets, it's probably not going to drop in price as much as usual tablets. But as tablets, they are cheaper than the monoclonal antibody mabs. So I'm just going to have a look. I'm being sidetracked by this. So cheetah with pants. Gepard. Yeah. So gepants, not gepard, but yes. Who knew cheetahs in pants could be so useful? Excellent. Well, if it could run away, if your migraine could run away as fast as a cheetah, that would be useful. I've just realised that I've missed a whole section that is between those other 3 preventatives and moving on to the mabs, and that is Botox. So Botox, for a long time prior to the monoclonal antibodies, was the last line in being used. And they're not exactly sure why it works, but they seem to think it is if you can relax the muscles around the area, it relaxes the nerves and the blood vessels around the area, and it reduces the triggering of the migraines. So unlike Botox for aesthetics, where you will be injecting where the frown lines are and the wands, for Botox, for migraines, they usually do the injections around the edge and then also at the back at certain areas. Usually every 3 to 6 months, depending on the person, for the for how long it lasts on the Botox. Obviously, this has to be given by a neurologist. It's not something that GPs are able to do. So again, you've got to have had a referral to the neurologist to start on the Botox. Although it's not available to everybody on the NHS. So you can, there are a few doctors out there at private clinics that actually will give Botox injections for migraines in a private clinic, but this would have to be an actual doctor in a private clinic that is trained to giving it on migraines. You would not have somebody who's just trained as either a nurse or a beautician trained on Botox for aesthetic reasons, cosmetic reasons. So yeah, so Botox is in there as the step before the mabs, but I think probably over the coming years, the use of the botox is probably going to reduce in with the rise of these mabs, and then possibly with the rise of the gepants. And then I was just doing a bit more searching, and they now have another line of medication similar to the gepants, but they're going to be called triptans. I think the first one has been released on the market. So again, it'll be good to know how that compares. Obviously, these are all new medications, so none of them will be tested in pregnancy or breastfeeding. For all new medications, we don't get any information on pregnancy and breastfeeding, because no company wants to do that research. It's too delicate. So all we have to wait for is for accidental exposure over the coming decades. Looking back, observational on data to see whether there does seem to be a risk or there doesn't, and then we end up with having a database of there seems to have been 1,000 people accidentally got pregnant on this medication. It didn't seem to cause any problems, or it did, and that's how we get the data for pregnancy and breastfeeding. There's not many companies out there that actually purposely go and test their medicines in pregnancy and breastfeeding unless it's to treat a condition of pregnancy. Also, with these newer agents, we don't know any long-term side effects, so we can have some short-term side effects that have been listed, like the constipation and the muscle cramps and such, like the nausea and itching, but we're not going to get sort of the long-term side effects that happen to just 1 in 1,000 people or 1 in 10,000 people, or only after taking for a year or a couple of years. We're not going to get that data until a few years down the line, which is always the risk that you take with new agents. So it's a benefit risk that you need to take with your healthcare professional of, are you at the point that you're that desperate that you're willing to try this, and if the does develop a problem, you'll deal with it when it happens. So I think I've covered everything that I've wrote down in my notes. Hopefully I've covered everything that everybody was hoping for. It seems to have quietened down in the chat, so I assume that means that you've either fallen asleep or that you've got no more questions. Okay, so hi Demi. No, you're not too late. I'm still on. You probably will want to go back and watch the replay. Maybe play it back. I've been on for an hour and a half. You might want to play it back at double speed. So there isn't any migraine specific treatments for the actual auras. However, we did talk about the fact that as soon as you start getting the aura, that is the best time to take the medication, because as the migraine progresses, your ability to absorb medication reduces. So the earlier that you take the medication, the more likely you are to get the full amount into your system and more likely to shorten the length of your migraine. If it does come to reducing the aura, the ones that would work for that would be the triptans, if you're taking a triptan, or these new gepants that are on the market. They would be the ones. Yeah, unfortunately. So, yeah, it was only after. The unfortunate thing with thalidomide was it was promoted as an anti-sickness drug for pregnancy. And that's why there was so much of a controversy, because GPs were actually purposely prescribing it for pregnant women because they thought it actually helped. And it wasn't until there was quite a few cases that they then went back, which is now why all new drugs come onto the market with the warning of do not use in pregnancy, and that we will not use this in pregnancy until we have done proper testing. And that testing, unfortunately, will start in animals if they are attempting to go for such like. Now, thalidomide is now back on the market purely for a severe type of leprosy. And when patients do take it, they have to be made so that they biologically cannot get pregnant, and putting that limitations, and that them limitations have actually now been put into a place on sodium valproate, because they found that sodium valproate, a medication that's been around for decades, but they've only just, well, they realised quite a few years ago there was a chance of fetal abnormalities, and they sort of said don't use in pregnancy, but people still were getting pregnant on it. They've actually now literally had to say anybody that's taking it must have a full-on pregnancy prevention plan. And that's probably going to move. We're going to get more and more medications now where as soon as they realise that there is a risk, we're going to be making sure that there is pregnancy prevention plans in place. Another one is the vitamin A derivative, isotretinoin, that dermatologist used for acne. Patients must have a pregnancy prevention plan and have a negative pregnancy test at each prescription. So, yeah, things are getting stricter and stricter in review of safety, which is also the reason why a lot of companies aren't putting as much into sort of getting licensing for pregnancy. So all new drugs automatically say do not use in pregnancy and breastfeeding, which can make it very, very difficult for people who have long-term conditions and still want to be able to get pregnant. And they've got to try and look through there of the data of how many people have accidentally got pregnant on these medications. Has there been any issues? Is it worth the risk? So, yeah. Okay, excellent. I appreciate all of the watch time. Currently, my live streams do provide me with the most watch time. I'm still a long way off even thinking about getting monetized. I need 3,000 hours of watch time and I'm only on 500. But it is my live streams that give me the most watch time. I haven't really got enough of my other videos up with enough hours. So most of my other videos that I produced are only about sort of 20 minutes long. And I don't have the same sort of footfall on those as I do my live streams to get them to actually count as watch hours. So any watch hours is appreciated. Also, looking back at any of my actual videos and putting comments on there to help the YouTube algorithm share my information to more people, I would fully appreciate, because I would like to sort of be able to educate more people and debunk as much medical misinformation as I can. So, yeah, auras, yeah, it can be the worst symptoms. As I said before at the very beginning, a headache is just potentially one symptom of the migraine, and not all migraines actually have a headache. Sometimes it can be all the other symptoms of the migraine that are much, much worse. Yeah, and when they're affecting your vision, yeah, it affects your ability to pretty much do anything other than sort of just maybe lay in bed and listen to the radio. And then sometimes the sound can be too much as well. Anyway, thank you all so much for joining me and asking your questions. I really do appreciate all of your support. And I'm hoping again for 3 weeks' time again for another live stream. Sunday nights seem to work better for me. I'm still doing the analytics to see whether more people can do a Sunday or a Monday. But if you've got any ideas of topics that you want me to cover, whether you want me to do a full-on live stream with a full topic like this, or whether you want me to just do bits and bobs of debunking medical information, just let me know. Excellent. But if there's anything that you want to ask afterwards, ask in the once the live stream's saved, ask in the standard comments, or even ask on the community page, and I'll do my best to answer them. So yeah, thank you, Lisa. Thank you, Lynn. Thank you, Sam. Thank you, Demi. Thank you, yeah, Jolie, and everybody else that's either been lurking in the background, including my mum and dad, I think, have been lurking in the background. And hopefully see you all again sometime. Bye.